again innovator and Dr. Priya Narang from India, who's going to be speaking on traumatic cataract with twofold. So, Dr. Priya, all yours.
Thank you so much, Dr. Gaurav, and all the panelists for this wonderful opportunity. I hope I am audible to everybody.
Yeah. Yes.
Okay. Thank you. Well, I will be just giving a brief insight into how I would like to go ahead with some of the cases, those who are traumatic, those who have traumatic cataract, and they also need an iris repair along with it. Now, iris repair is one of my favorite topics that I always keep on talking about. This is one of the cases that I just did recently, last month. This is a case of a traumatic cataract with massive iridodialysis. So now these are the cases, these are the cases that they actually need a lot of planning pre-operatively. You need to formulate all plans A, B, C, D. If this works, if this does not work, what you do, because you have to be mentally ready with the, all the things that you will be doing for this case. Leave aside the technicalities, but all the plans should be set in place for these kind of cases. So now, I just thought that let me go ahead with discussing traumatic cataract with massive iridodialysis and how I go about with this. So one of my favorite techniques is the twofold technique that I try to adopt for iris repair. Traumatic cataract, we all know how we go ahead with and how we manage and how we try to prevent the vitreous coming in front and all the other procedures to fixate the bag and everything. So today I will be emphasizing much more on the twofold technique. This is actually a technique wherein, it's applicable only in cases of massive iridodialysis, wherein you need a combination of one or two surgical procedures to handle. Now, I just go through this animation video. This explains how you handle the iridodialysis. The first part is that you can handle the iridodialysis by non-appositional method described by Dr. Snyder, as you are seeing in this case. If you have an eccentric pupil, especially in cases of massive iridodialysis, you also need to center the pupil. So for that case, you also need to combine this with a pupiloplasty procedure. So this is what we actually call it as twofold technique, and we published this in JCRS around 5 years back. So the surgical procedure of choice is single pass 4-throw pupiloplasty procedure, and this is, I'm just running through this animation video just to showcase how the surgical procedure is done. We usually take a 9 or a 10 polypropylene suture, which is passed from one end to the other, and we just pull this out. Initially, it was also called as the modification of the Sieps's method. Initial steps are definitely similar, but there is a turn to this that we end up taking 4 knots. And I did a study wherein taking 4 throws in this method holds the pupiloplasty into its place. You do not need, it obviates the need to take up a second pass. So this is how this technique actually derived its name as single pass 4-throw pupiloplasty procedure. And this I described with Dr. Ramar 3 years back in European Journal of Ophthalmology. So going ahead, this is just a clinical video. I would just show you a combination of the procedures where I try to handle a traumatic cataract along with the twofold technique. So in this video, what I'm trying to show you is a modified sewing machine technique for iridodialysis repair along with single pass 4-throw pupiloplasty procedure. So now this is a case, a young boy, he had this traumatic cataract along with the iridodialysis. The iridodialysis is quite a bit. It is around 120 degrees or so. So going ahead with the normal cataract extraction, as we usually do in all the cases, I have nothing to emphasize out here, except that, whenever you have an iris coming up into the center, it's quite obvious that we need to use iris hooks and you need to retract the iris. You need to clear up the pupillary plane because you need to view the center of the globe. So once you have done with and you have placed the intraocular lens, so now comes the real challenge of doing the iris repair procedure. So now actually what you are now seeing here is the modified sewing machine technique. Herein we take the nino suture and it is passed into this loop fashion into the from the entire area of the iridodialysis. One end of the suture is then cut and it is passed through all the loops, and then you take up the throws and then you tie it up. This is a bit different than the original sewing machine technique, which has been described, wherein you cut down all the loops and you keep on suturing the adjacent loop with one another. So it's just one single procedure, and it's quite a little bit faster procedure as compared to the sewing machine, and you do not have to take multiple you don't have to make multiple knots during this. So this is how it is actually handled. You do a peritomy across the entire area of iridodialysis. Whatever degree of iridodialysis you have, it is always applicable. The only thing is that you need to understand how much amount of iris tissue you are going to imbibe into that suture needle. You can go ahead with around 27 gauge needle or a 30 gauge needle. What you saw initially was I just threaded the suture into the barrel of this needle, and then I'm trying to create the loops as you saw in this in the previous animation video. The only critical point in this technique is not only in this technique, but in every technique of iris repair, is that you need to know the amount of iris tissue which is coming up in the needle, because if you intend to take too much of iris tissue into this, you might have an eccentric pupil. But many times clinically we have seen that it is actually very difficult to calculate the amount of tissue that you are taking up into the needle, because many cases are long-standing cases. And whenever you're handling a very long-standing case and trying to do an iris repair, many times it tends to cut through. Now, another thing that I want to show in this video is that the going gets tough, that you have to see and you have to correlate how many amount of loops you have had. I don't know if anybody observed, there was a slippage of one of the loop just right now. This loop, it tends to go off. So there should be a method where you can hold this loop, and the simple thing is that you can keep on counting 1, 2, 3, 4, 5, how many loops you have created. Because when you try to pull on the next loop, the previous loop tends to slip back, and you need to hold that loop, and that loop goes in. So actually, during this, to be very frank and honest, I did not realize that there was a slippage of one of the loops until I edited my video, and I realized that, oh yeah, I had a slippage of one of the loop inside, and I'm realizing it right now. But actually it did not make much difference, because even if there was a slippage, there was a next suture which was there, and it was holding the iris into place. So these another technicality in this repair is that many times iris tissue tends to bleed because it's a very fragile tissue, and you might hamper one of the blood vessels. So I just cut off one end of the suture, and I pass through all the loops, and then I'm just trying to take this knot. So this is a simple thing which comes up, and you are done through this procedure. But the downside of this is that you also need to calibrate how much amount of tension you have given to the knot, because if you pull it off quite a bit, then it tends to retract what you are seeing here. So now I'm trying to do a single pass 4-through pupilloplasty procedure in this case. And this is a single pass, and I'm trying to pick up the suture loop. I'm trying to retract this outside the eye. I'll take 4 throws. Now, the concept of 4 throws comes because, you can keep on taking as many throws as you want. You can take 4, 5, 6. It's not going to slip unless and until it is less than 4. Because 4 is the minimum. It's the optimal throw that holds the tissue into place. You can take more throws, but it will just add to the bulk of the iris tissue out there. So this is how it actually looks in the post-op period, and I believe that the combination of using and actually knowing 1 or 2 advanced surgical procedures for iris repair, it actually helps you out during such complicated cases. So there's one more thing that I just want to highlight. If you want to do a 2-4 technique, many times if there is a small iridodialysis and you don't want to go through many times through this repair, we also try to narrow down this area of defect, so that you can just go ahead with 1 or 2 non-appositional double arm suture, and you can just go ahead and you can fix this up. So this is just one thing that I just wanted to highlight for this. So yeah, thank you.
Can I